farms by using preclinical detection. The floor is yours, Jose.
Well, thank you very much. What I'm going to present is, I'm going to follow on Angus' presentation and talk a bit about early detection, but the context is going to be very different. Now we are not trying to detect the first introduction. What we are using here early detection for is to control transmission following the first introduction, which we clearly missed. When it happens, we now have to dealing with reactive surveillance. I also want to thank the organizers for putting me after Angus Cameron, because he has put the standard very high for this presentation. I will try to do my best. And why we are talking here is about early detection and subclinical detection. And why do we want to focus on subclinical detection? Because it has been shown, and this is data from Brian Charleston that was published in 2011, that most of the transmission takes place at the onset of clinical signs. When we see the vesicles, when we have clinical signs, is when the animal is transmitting most, is passing the infection to other animals. Well, before the onset of clinical signs, the transmission, it does happen, but it's very limited. And this was also shown before by Karen Orsol. Some of her data was also presented by Simon earlier. And I just want to paraphrase what she wrote there in her paper in 2009. Only few secondary infections are to be expected from infected calves when they are not clinically infected. So here comes all the subclinical detection. We want to detect it because there is low transmission, and that's expressed here in terms of the reproduction number. Simon Gobbins explained what is this, and what we are interested here is to have this value below 1. And when this R value is below 1, we assume that transmission is an epidemic is going to die off. One infected animal or one infected farm is not able to transmit the past infection to. It does, but it will die out in the process. And why do we think this transmission is not taking place in the subclinical phase? Well, here I'm taking some data. These are PCR values here. Sorry about the size of the text, but we try to analyze shedding of foot and mouth disease and also shedding of foot and mouth disease in the different states of the infection process. And in the first you will see here the clinical phase. This is the clinical phase, and this is once the animal starts recovering, early recovery. And what you can see is already there is way lower shedding in the subclinical phase. This might have a relationship with the probabilities of transmission. We see more shedding in the clinical phase, and that's the moment where we see that there more transmission is going on. So the question then comes, will detection during the incubation period stop transmission in this subclinical phase? And that's what we want to check. The good news is that now we have PCR, and we have seen, and there are many of your experiments going on, where they show that you can detect already genome 1 day post-contact infection. The animal got in contact with the infectious animals yesterday. Today you already have a PCR signal. So that's a kind of good news if we want to do surveillance. And we want to focus on early detection, in this subclinical detection, to stop transmission. And that was the objective of this work, was to evaluate the potential of preclinical detection during reactive surveillance, so different scenario to what Angus presented. Angus was focusing on trying to detect the first introduction. Here we are already in an emergency. We want to stop transmission using surveillance, preclinical detection. And we want to stop transmission between farms, not from animal to animal. One infected farm is already a lost case. We are going to slaughter the whole farm. And to do that, Angus said, we have 2 important things. What we are going to use, the tools. We need to use diagnostics. We need to detect. And then we start worrying about the sample size and how often we need to go. Those are 2 very important questions when we are dealing with surveillance. And of course, and that is all this talk about, and which standards we are going to use to measure this early detection. I'm going to go about that. And to do that, it's not as simple, the model we are presenting is not as simple as the model that Angus presented, but it still is called a simple SIR model. And what we do with this model is try to simulate the dynamics of an epidemic in a farm. So in time, how many animals go infected, because that determines how many samples we need to take for the epidemiologist. And in these dynamics, what we know that is in time how many animals are preclinically infected, how many animals are clinically infected, and how many animals are recovering in the process. We never know when the farm we are going to sample got infected. We never know what that farm got infected, especially if you don't have clinical cases yet. So what we are going to do is any random day between a sampling interval that we will go sampling. And then based on that, we also need to worry about how many samples we are going to take, which determines our sensitivity. And once we detect this farm, what's going to be the effect, the impact of this detection on transmission. And we measure this with this reproduction number. It has to be below 1. So let's show some results of trying to use some sampling methods we usually use during our studies, using nasal swabs, proben samples, esophageal samples, saliva swabs, or serum samples. And what we try to do is check the sensitivity of use of these sampling techniques during the preclinical phase. Well, here you see the sensitivity in the preclinical phase, clinical phase, and early recovery. And what we can see here, which is good news, this PCR, is that in this preclinical phase, for most of the samples we take, the sensitivities are above 80%, which is quite a good sensitivity. We also said, okay, let's try and check some group level sampling. Let's check air samples. There's some work going on with air sampling. Also, I think the group in the USA also tried to measure this, and we used their data to come with some estimates of sensitivity of air sample from rooms to try to use this at the hair level. And the idea is more simple. You don't have to go and sample every single animal. You will just, in a dairy farm, for example, go to the milking parlor, pull a sampler like this, where you have a cone here or a tube that do the air sampling, and then the farmer can just go and remove this cone here and bring it to the door, so the vets don't need to go in and get the sample, bring it to the door, and somebody who is using something like LAMP can just test it right away, or a mobile PCR, so that's making the system faster and efficient. So these are the measures of the sensitivity. And then, well, but this alone doesn't tell us anything. Then we need to know how many samples I need to take and how often I need to sample. I am in emergency. Do I need to go every day? Do I need to sample all the animals? 1 year sample will be enough. So we need to determine this. And for this, we do the modeling. I will explain the results, the scenarios we check, but I go back a bit to what the model is doing. Well, the model is expressing this is all the prevalence of infectious output during an epidemic. And we express this, all this is the infectious output, and it is the reproduction ratio, or the transmission potential of an infected farm to infect other farms. And what we want to do is be early. In all this infectious process, if we detect here, probably we are early. If we detect here, probably we are late. The problem we have is we don't know when this started in time. So it has to be, we only know that probabilistically we go at a random time, and given this, we need to know how many samples take, and if this is going to be enough with the frequency. So these are scenarios we test. Sorry, in this axis, what you have is the R value, and what you see in red is something has changed here. This should be at 1. These red lines should be here in the number 1, and that's the threshold for us to say this is early detection. If these bars are below this red line, they are still below, so that's good news. It's that we are claiming that we detected the infected farm before this transmitted infection to another farm. And what you see here is in a case where we have no control at the beginning of the outbreak. This was the R0 value in UK in 2001 in the first weeks when no control measures were implemented, was around 3, the upper confidence interval and reporting. This is in a scenario where the farmers are reporting the cases, and only the farmers report the cases when they see the clinical signs, which we see here is still above 1. It's 1.7, above 1.5. So that's not enough, and we know that. We saw it already. We see this already during the epidemics. We are quite late. The farm has transmitted to other farms already. But if we take, in this scenario, for example, if we take 10 random samples of saliva swabs, I'm going to think about saliva swabs, 10 samples, and we go once a week, we are going to reduce the chance of transmission to other farms. So actually, and we consider a scenario when we are in an area with low farm density, so less risk there, going a bit in line with what Angus was talking. So the risk of transmission is lower because farms are less densely populated. So there's more distance from one to the other. Maybe we should consider that, we don't do vaccination, but we can consider this preclinical surveillance, subclinical infection. This could be an option we can evaluate. And actually, we can use, for example, saliva swabs to do that. And we need to visit the surveillance once a week, take 10 samples, and test that.
Jose, there's one more minute for you. Is that okay?
Yes, I'm finishing. This is a worst scenario. If the virus is transmitted faster, it complicates. We have a shorter latent incubation period or latent period. It's transmitting faster. We still have room. We only have to deal with higher number of samples. So, in conclusions, preclinical detection can be expected to reduce or stop transmission between herds. At least all this predictive work, but it's giving us some standards to show that we can use this as a control tool, use surveillance also for early detection as a control tool. And there are good options for this. And I would advocate here we have checking also air sampling at the herd level, I think can work for dairy farms. But also I would advocate for saliva swabs. Cows are very, very curious. If you go with the swab, they come and lick the swab, so you can give 10 suitable swabs to the farmer, and the farmer will go and make their animals lick and can come to the door. And somebody with the test, like the group of Peerbright developing these portal PCRs or lamb tests to test in situ, they can just wait at the door of the farm without having to go inside and deal with the animals and look in the mouths and trying to move transmission and test right away. That is going to improve biosecurity during the control process. And that is all I have to say, and I think these are the funders, the FRBB, SRC, and now I'm presenting on behalf of Noel Nelson, and this work I did while I was at Peerbright. Thank you.
Thank you very much, Jose. Very nice and interesting presentation. Are there any questions from the floor? Let's see.
Right. Thanks, Jose. That was a really great presentation, and I'm a big fan of that approach. It's very impressive. We heard some really good talks yesterday about the problems of resource allocation in contingency planning and in managing disease outbreaks. Have you guys thought about the resources that would be necessary to do this? Say, I presume you mean to do it in a 10-kilometer zone around an outbreak, something like that, and how this could be operationalized, because it seems that there would be quite a lot involved in actually getting this up and going. You'd need to prepare it a long time in advance to make it practical.
Well, in a way, I would think it would be simplified in terms of if we think of saliva swabs, the vet teams do not need to go inside the farm and take the samples themselves. You can just give these swabs to the farmers, and the farmers will go in the herd and let their cows lick the swabs. Cows are I'm a cowboy myself, and cows are very curious, and they just approach and lick the swab. And the same farmer can just go and give those samples at the door to the field teams, the vets, and the vets can do the testing right away or ship that to the lab. And I think we still need to move and consider this option as a control option in most of our modeling, because up to now we have been doing all these epidemic simulations to try to improve our emergency preparedness and see how we are going to react with vaccinate, don't vaccinate, vaccinate to live options. Well, this is a new option that can be also introduced in all these modeling scenarios, and the cost also later on be applied to it.
Thank you. Just one more question, then in the back. Thank you.
Actually, a comment more than a question. The concept of preclinical swabbing, I'm all for that. I think it's great, and it is predictive of what's coming down the road. I just wanted to mention that you might consider swabbing different parts of different animals, because oral swab of a pig is very reflective of their early phase of infection. But cattle, for instance, In the preclinical phase in particular, it's the nasopharynx where you are more likely to find the virus, and so I would recommend a deep nasal swab in cattle. Pigs, I agree with you, saliva is a great tool. Sheep, goats, camels, I'm not sure, but each species you might consider differently.
Well, I should correct, all this works based on cattle. And in one of the slides, we checked the sensitivities of preclinical detection for each of these samples you mentioned, the nasal, the probang. The probang was the most sensitive, actually. Probably it's good if I go back there. The probang samples were the most sensitive. You are correct. But then the saliva swabs and the nasal, they had also good sensitivity. And the idea is to make it more practical, more efficient, and biosecurity based. And this level of sensitivity, this 80% against this 95, is still good for early detection.
Okay.
And it requires less resources. So
Thank you very much. Thank you very much. And then give you a hand again.